We are back to Crimson Courage, and our guest today is John King. So, John, please tell me, personally in your life, have you been affected in any way by sickle cell anemia?
Yeah, I have. Not directly, but within my family, extended family members, friends. I've got a number of friends who I can see having this kind of challenges. But I remember when I was growing up, I couldn't understand what sickle cell is. And I remember back in the village, I come from Homa Bay. So, and you know, the Lake Belt region, as you move through the water mass, these high prevalence rates of sickle cell. And very young, at the age of 5, 6, when in nursery school and all that, I lost a very dear friend at that time. That was way back in the late 80s. And I never understood. What caused the death. So later on in life, when I went to study medical laboratory sciences, started learning about what sickle cell is all about and how you determine that and all that. And as I continued in my practice, I met quite a number of people. And I got married as well. And as the family became bigger, you kind of notice a few challenges that happens. So I've been personally affected by close family friends, and also very close relatives that I've lost through sickle cell. Some are also acquaintances in the industry that I've also lost through sickle cell. So yes, I can say I may not directly have had a direct loss, but indirectly through close relations, close extended family members, yes, I've lost quite a lot. I have friends who've lost children, and which breaks my heart a lot. I've used to see some of the children going through the crisis, and you can't imagine the amount of pain. I have friends who've recently discovered that they have a child who has sickle cell, and they're still going through understanding the whole thing around that. So yes, I can say yes, I've been affected in one or another. And that is my driving factor, being part and parcel of addressing sickle cell. Working through Hemex, it speaks to what I believe. I believe that we can make great impact and direct impact and change lives by analyzing early, getting to care and therapy and the like.
Okay. So when dealing with sickle cell, what are some of the misconceptions that you found are quite common, even both in professional sectors as well as socially?
Professionally, I don't see much of a problem when it comes to sickle cell, because the professionals understand what sickle cell is. Sickle cell is not a new disease. It's been there since time immemorial. But in our social construct, the social setup, especially in Africa, that's where the biggest challenge is. There's a lot of stigmatization that goes with sickle cell. People don't understand what sickle cell is all about. And then you see, as a sickle cell patient grows and they continue to grow, they face physical challenges that comes with it. Some deformities, some also loss of weight, some also, you know, they're susceptible to diseases, bacterial infection and all that. So there's a lot of problems when it comes to social construct. From a village point, from, you know, living situation around people, you find some children are still being kept and locked out. Why? Because the society think that they're children of witchcraft. Yeah. You know, when we were young, and you see these big Indian families and all that, and you find one member not too well, you know, what we would call normal. I never understood, because there's also beta thalassemia that affects. Okay, so more often than not, because we don't understand the disease that we have, we equate it to the next best thing, which is witchcraft, and this hinders early detection. This hinders therapy. This leads to abandonment. I've seen families breaking because the husband does not understand that this is sickle cell. This is not a child that was, conceived with a mad person somewhere. So it breaks, really it breaks the emotional part of human being when the social construct is not educated sufficiently to a point to understand. But this is also not very strange. Because maybe you, Tracy, you were not there back then, but in the mid-80s, when HIV AIDS started, moving very fast in sub-Saharan Africa, and up to the mid-90s here, when people were dying quite a lot, there was a lot of what we face today with sickle cell. Okay. Now, imagine HIV was just 1980s here. Started 1980s, 84, it was quite a lot and all that, and then you move along. And we've overcome that stigmatization. Now, sickle cell, these guys have been living with this stigmatization from time immemorial. Okay. You see. So I think there's a lot more that needs to be done from a social education standpoint, from advocacy standpoint, especially geared toward demystifying what this condition is all about. Because I can tell you, I've met several warriors in Africa. I've met warriors in Kenya. I've met warriors in Zambia. I've met some of them in Uganda. You'd be amazed the kind of things they do. Okay. These are the most brilliant individuals I've come across. How they are able to even withstand pain with me, with my normal self, a small bit of pain here, I want to take medicine. And this group, this vulnerable group, must be given chance in the society to live, to exploit their talents, to express themselves in a way that they can positively contribute to a societal growth. And so yes, those are some of the key things that I pick out as I move along and I see different places. And we have not reached the last person. Okay. I wish you could have a drive that talks of leave no patient behind, we must find out from the family tree to the affected. Private sector industry need to come together. We need to address sickle cell wholesomely, both in terms of diagnostic and therapy management and social economic management as well.
Okay, that's interesting. So even in different communities within Kenya, you find that there are some who they don't really know much about sickle cell because it's not prevalent within that area. However, because of urban to rural or rural to urban migration, you find a lot of people have actually become sickle cell carriers or carriers of the trait without even knowing. So as a professional under Hemex Health, who would you recommend to actually go and get tested or do screening and know their genotype?
I'll start from what is currently known. There's misconception. I call it misconception today because it wasn't a misconception before. It was always believed, I'll take a case of Kenya, that sickle cell is a Western Kenya disease. By Western Kenya, I mean Western Nyanza as a whole. So look at that belt. And yes, truth be told, yes, those are the high prevalence areas. But you see, over time, there is a lot of intermarriages. There is migration. Nobody knew that urban setups like Nairobi, you'll have sickle cell. But today we are picking up a lot of sickle cell situations happening in the urban setups. And of course, maybe not in the same proportionate level as the rural, but it's growing. So to answer your question, who should be tested? I think each and every person need to take the responsibility to know their genotype. It doesn't matter which tribe, which region of Kenya you come from. It's good to take that initiative and know whether you are carrying the sickler gene, either as a trait or as a sickler gene. Because that is the only way we can mitigate some of the eventualities that will come in the future. Otherwise, without that, then there will be more propagation, and with more propagation, there will be more of sickle cell progression in in the societies, and that becomes a challenge. Secondly, the buck stops with the healthcare industry, and in leadership, this is Ministry of Health. So the Ministry of Health needs to really do a lot more. Sickle cell is domiciled under non-communicable diseases. Nobody looks at non-communicable diseases as serious stuff, you see. It's only these days that there's some kind of activity. Cancer has gotten some level of activity, diabetes has gotten something, asthma, hypertension, those kind of stuff. But you see, those are classified as lifestyle disease, you see.
True.
Those are lifestyle disease. Some people make jokes like those are rich man diseases.
True.
You see, sickle cell is a poor man disease. It doesn't matter whether you're a billionaire. When the crisis hits, it hits the same way that poor person feels it. You see, it does not discriminate, and access to care is also that limited. We have care like gene therapy, bone marrow transplant. All those are very expensive. So the more the industry, private sector, public sector come together and address the concerns that are within the infrastructure to address sickle cell, if that is not done, then we are going to be back to the same cycle of activities. And Ministry of Health needs to put this as their focus. Lastly, I would say the drive should and must be taken up by our policymakers. Your politicians, Yeah. It's not enough for them to just come and tell you, I'll build a road, I'll build a toilet over there, and you see funny stuff. What are they doing in terms of protecting the vulnerable? The sickle cell community. These are also voters. These are also people who contribute positively to the society. What are the initiatives, which kind of initiative do they have in their programs to ensure that there is more advocacy and bringing people out of the homes, demystifying, stigmatization, like what we used to do, the whole program of HIV. We involved everybody. Sickle cell should not be given, lip service. It needs to be addressed as a holistic, because you can never walk around and see somebody and say, oh, that one has sickle cell. Not at all, not at all. In as much as it's not a communicable disease, it is a condition that is life-threatening, really life-threatening. And we continue to lose. I mean, look at the figures that we talk about sickle cell worldwide. Out of 500,000 babies born every year with sickle cell, you find 300,000 of those in Africa.
Wow.
And high chances of those 300,000 not making it past 5 are extremely high. Without those intervention of hydroxyurea and all those kind of things, it is really, really difficult. Now imagine you get to know that you have sickle cell when you're now in advanced age. It's really difficult to manage.
That's true.
The toll it takes on you. But if we can start early, those screening exercises. So it is a consulted effort. It is not a one-man effort. It has to be a consulted effort from individual. So individual, we should take responsibility and that initiative to know your
genotype.
Yes.
Yeah.
If you have a girlfriend or you have a boyfriend, before you celebrate those days that you met or those occasions, one of the gifts should be sickle cell testing. If you have a child, as a parent, one of the things you need to request when you go to hospital, when you go for clinics, is sickle cell testing. If you're going for clinics, sickle cell testing. If you're going for blood donation, you're going to donate blood for somebody, request those guys to do for you sickle cell testing. It is very important to know. Knowledge and information is power. Otherwise, it will become more of a sad story over and over again.
Wow. So the message clearly is know your genotype. When we come back to Hemex Health and the Gazelle machine that they have, what is actually the strong suit of the Gazelle when it comes to sickle cell testing and being able to know your genotype?
Thank you. So for that, I brought my this reader. This is what we call a Gazelle. This is you can see it's written here, Gazelle.
Yes.
This product is made by a company called Hemex Health. Hemex Health. So Hemex Health make this HB electrophoresis. We call it a miniaturized HB electrophoresis machine.
Okay.
Okay, because it's small.
It's portable.
Normally, electrophoresis are normally huge, but this is a miniaturized one. Now, the advantage of this is that, one, it is portable. Okay. Two, it can work in temperatures, extreme temperatures. Like in Africa, we have temperatures of 35, 40, 45. So this machine can work in those setups. Secondly, it has a battery backup. So meaning it can be charged. When it's fully charged, you can use this for about 8 hours without charging it. So it's a very good tool for medical camps, for primary healthcare facilities, decentralized care infrastructure systems. This tool, it fits along the chain. So whether you want to use it in the laboratory or you want to use it in the field. The other point is it's very easy to use. There's a lot of explanatory. You don't need an expert, like a proper expert to do analysis on this test, on this tool. And then secondly, it gives you results in terms of quantification of results. Today we talk about HPLC being gold standard. The results you get out of this Gazelle tool are comparable to HPLC.
Okay.
So you'll know your levels. So when you talk about your S gene, what percentage is it? When you're talking about fetal hemoglobin in children, what percentage is it? When you're monitoring somebody who has gone through transfusion therapy, after time you have to monitor the fetal hemoglobin and see what's happening there. Somebody who is under hydroxyurea therapy, you need to monitor that. So this tool, this reader becomes very important. The other thing is, it is quite cost effective, right? Meaning we are bridging that gap of cost to care. So it's quite cost effective in each and every country. And also, the reagents or the kits do not require cold storage. So it does not put another extra cost on burden to the healthcare infrastructure. So those are the key benefits out of this tool. It uses AI technology. So meaning you're able to, it's able to read in terms of algorithm. We are able to test from a newborn to an adult across the whole chain. We have all that information stored in the backup. And transmission of data. So basically the test on this tool will take about 10 minutes. Yeah. In today's world, especially in Africa where we don't have a lot of HPLCs, is that if you go to the hospital and you want to do HPLC test for sickle cell, chances are you'll get your results in 2 weeks.
That's true.
Worst case scenario, best case scenario, a week plus. But high chances are, most cases is 2 weeks. Now, 2 weeks, what are the chances of crisis? What are the chances of other infection? What are the chances of... So there's a lack of intervention that goes to care when there's a long wait of period. But here's a tool that bridges that gap. That means decision can be made at the clinic and intervention can be made, the right intervention, and pathway to care can be activated. Yes.
Okay. So let's speak of numbers. When using the Gazelle, you've said that it is an affordable way to do an electrophoresis test. Now, even back in the day, getting electrophoresis test was kind of a challenge, whereby you'd find even getting blood samples sent abroad so that someone can get conclusive results. So when we consider that and the size of the machine, what do you mean by it is more affordable in comparison to maybe HPLC devices that we find in hospital setups or traditional setups? Yeah,
so HPLC has always been, well, there's a long history of how we came to up to these levels and rapid diagnostics. But HPLC has been the gold standard. And one of the challenges of HPLC is that in many cases you have batch samples, meaning you have to collect number of samples for you to run. Because the way the HPLCs are designed, first of all, they're bulky instruments, meaning you cannot use them at a primary healthcare facility. You need to possibly have them from level 4 going upwards. Now, many of our patients, many of our people are not able to access those level 4. Remember, there's distance, there's economic challenges, cost of transport and all that. That is one challenge. So one is the bulkiness of what currently we have in terms of technology. Two is the cost of that technology. An HPSC system is very expensive. Okay. For a facility to acquire an HPSC system, it costs a bit of money, right? So not so many facilities can afford it. Again, as I said, sickle cell is not a funded disease. Okay. You see, if it was things like TB, malaria, HIV, big machines are normally, you can find fundings to run around. But sickle cell and beta thalassemia, these are not diseases that are funded. So it has to be out of pocket. Now, those who can afford out of pocket for running HPSC, they have to wait for those 2 weeks to know whether they have it or not. Yeah. You see, that also built into those challenges of HPSC. So the limitation of HPSC is that there's very little leg room to play around when it comes to that patient to access care. Okay. It's either you run a program and collect samples from the field and come with them to the laboratory and do the test. If you don't store these samples correctly, you have a problem. Yeah. If you lose the samples along the way, you have a problem. If you don't, the high chances of cross-contamination, problem. Now, again, consumables, you will need tubes, you need pipette tips, you need this. Yeah. So it builds up to a costly affair. This kind of a tool can be very close to the patient. This is what we call near bed kind of monitoring device. Meaning you can take it to a patient's bed and do the test there. You can have a medical camp and do the test there and have the results also out there and there. And this reduces the total cost. Now, I can tell you, I cannot tell you exactly how much it costs per test, where we place them, because that will be moving to our partners around. But I know, even from what they charge to facilities, is the difference between HPSC and which our partner, Kenyan partner, charges, I would say is close to almost 1% of what HPSC would cost you. Okay. 1 to 2% of what HPSC would cost you. Wow. If you say today I want to do HPSC test for sickle cell, that particular cost is about 1% of what this would be. That's what we mean by reducing and bridging the cost gap.
Okay. Yeah. Wow. So Gazelle is actually a genius solution for sickle cell screening, not only in hospital setups, but even remote setups. Yes. Because I can just actually put it in my backpack and easily move to where I need to actually run tests.
You can charge it in your car because it uses normal charging. Okay. Yeah. So basically it's like having a mobile phone in a big case. Let's put it that way. Because that's the whole analysis, the whole AI technology incorporated makes it easier to use it in the field. So you can charge it in your car, you can charge it in your office. And as I said, comparison to HPSC, sometimes you have to batch samples. So if, Tracy, you want to do an HPSC test, chances are I have to wait for a few other more people to come on board so that I can reduce reagent cost. But with this one, is 1 cassette per patient. Yes. So if a patient walks in now, I can test them and then they can go and get intervention. I don't have to collect samples and stay with them there forever and wait for others to come. Then I can build up, what we call a multiplex kind of a thing. Right. But one thing, our HB electrophoresis, the aim and the way it is designed is to do more other tests, not only sickle cell and beta thalassemia. But today, we are able to pick all the traits. So you have the A, you have the S, you have the F, you have the A2, the A, C, and E.
So you mean percentages? It shows the percentages.
It shows you the percentages of those tests.
All right. Yeah. And does it need any other supportive device, maybe a computer or a printer?
Not necessarily. So it's a choice in the structure. Again, because we want to have this decentralized, the whole concept of point of care is to ensure that it is at the lowest level possible, where there is very little infrastructure. Yeah. Now we are incorporating a couple of things. We are incorporating barcode scanning for results. So You get a result out of this machine, you're able to scan it and move forward, but those are things that we are toying around to see how that would work in the future. Okay. But we are able to do printing out of this, because you get a full result with the percentage, and also you get the picture of how electrophorese happened across the chain. Okay. So the initial reading of a sickle cell is, back in the day, the initial science of doing it was using a slide, a lab slide. Okay. So you'd pick blood sample and somehow starve them without oxygen to see whether
so
they
mean
sickle.
Putting between the glass slides and looking under a microscope?
Under a microscope. Okay. Now we're using what we call electrophoresis, and incorporating a dye to electrophorese. So it kind of that gives that light, that color that we put as part and parcel of the sample is what makes the lens to be able to reflect. So it uses some lights to do that kind of, that's what we call electrophoresis. Okay. Now this one, it incorporates percentages, so it gives you quantification. Okay. At what level are you? Like, for example, when you're checking fetal hemoglobin, it's a very critical thing. Sometimes you find fetal hemoglobin very high. Yes. You know? So interventions are different. So this allows the doctor to determine what regimen to put you on, and even the kind of drugs that you need to be on. Right. And it helps you to do the monitoring. That's the advantage of getting quantification result. Okay. And then if it is a pathologist, out of the result that has been quantified in percentages, they can, on the side, they will be able to see what that slide film looks like, because it gives you the picture of what was happening on the cassette. So it gives you like a slide image out of it. Yes. All
right. Thank you, John. Then
most welcome.
Let's go and see how the test works, yeah?
Pleasure.
Asante sana.
Thank you very much. Thank you for having me.
Let's go and see.
How are you?
I'm fine, thank you.
May I sit?
Yes, yes. So, karibu sana.
Asante.
Today you have chosen to come and do your test.
Finally.
That is very good. Hi, my name is Scholastica Sambu, and I am inviting you to Crimson Courage as I take you through the testing of sickle cell using Hemex Gazelle machine. Welcome.